welcome everybody. Thank you for joining us today. My name is Elaine. I'm from Workit Health. If you are not familiar with Workit Health, we are an online addiction care company. You can learn more about us at workithealth.com. We like to host community events like this one to support recovery and mental health. And the topic of tonight's panel discussion is tapering off Suboxone. And we are joined by some of Workit Health's amazing clinicians. We have Kevin Armington, MD, Eric McClimans, C.N.P, and Melani Mood, L.P.C. I have some questions for you all, and we will also have the Q&A box open. And if our attendees have any questions, you can drop them into the Q&A box, and we'll try to leave some time for that at the end of the panel. And I would like to begin by inviting each of you to introduce yourselves and give us a brief background of your experience with addiction medicine. So Kevin, would you like to start us off?
Sure, I'm happy to. I'm Kevin Armington. I'm the supervising physician for Workit covering Ohio, Florida, and New Jersey. I'm primarily a primary care provider. That's where most of my career has been spent. And I became interested in addiction medicine soon after I started doing primary care. And because I realized that you couldn't really make much headway with primary care issues of patients if they were actively using drugs, and I couldn't help them with that, or alcohol. So for about 15 years, I've been actively involved in addiction. Serving as medical director of some outpatient programs, a large methadone program in New York City, and more recently as the supervising physician for a couple of states, as I mentioned, for Workit Health. And I'm a big proponent of buprenorphine, Suboxone, and be glad to share my experience with you and answer any questions you might have about tapering off or other aspects of Suboxone treatment.
And then Eric, would you like to introduce yourself?
Eric McClimans. Hello. Like I said, my name is Eric. I'm a certified nurse practitioner in the lovely state of Ohio. I do work with Dr. Armington as a collaborating physician. My experience is quite unique. My addiction experience goes back to as a child. I had an older sister and some other family members having substance abuse issues. And so I started learning about this process at that point. When I became a clinician in my 30s, I went right out of grad school into addiction medicine because I felt that these are my people and I needed to make a change in these individuals that were struggling, because I saw firsthand how there was not a lot of help, not a lot of people out there willing to help, if you will. So I started in probably 4 years ago, and I started in a clinic in Columbus, Ohio, ran the clinic from a medical director standpoint, and then I got the knack for telemedicine. So I've made the transition to telemedicine with Workit Health almost a year ago, and I love it. I love the capability of reaching more patients than what I could in my bubble in Columbus. So I'm certified in family medicine and obviously able to treat and understand addiction and mental health disorders as well.
Thank you. And Melani?
Hi, I'm Melani, and a lot of similarities with Eric. I started learning about addiction as a child. My dad had alcoholism, and my mom was a real big influence on making sure that we had those mental health supports and people to talk to. And then later on in life, my sister ended up developing an addiction that progressed up until our mom passed. And then the day after, just trying to calm the grief, she actually had accidentally overdosed, and we lost my sister the next day.
Oof.
So part of my targeted efforts at constructive and healthy grief and processing, I went back to school and finished and just kind of kept going and going and going. And it was always focused in addiction. I tend to be a little bit macro and micro, wherein I can sit and understand where someone's coming from and be able to validate those feelings and kind of look underneath. But at the same time, I really do enjoy giving a voice to this population and doing it from an empirical perspective, so that everybody's on the same page, we're using the same language, and we're working together toward a common goal. Because like Eric said, it's just such an underserved population with, I mean, so it's just a very exciting thing for me to have been spending the last several years, you know, writing grants to get MAT programs up and running, and having legislation turn them down, and find an organization like Workit that comes from my same ethical and value standpoint, and focuses on that with everyone I come into contact with every day. So it's really exciting work to see, and I'm really excited to hear what Eric and Kevin have to say. It's really very cool.
Thank you. So the title of this panel is, you know, tapering off Suboxone. So I wanted to start with the very basics. What do we mean when we say tapering off Suboxone, or, you know, when are you going to start your Suboxone taper? And as we ask questions, anybody can jump in.
I'll let Dr. Armington go first with the
Sure, I'd be happy to address that. I think it helps to think about what Suboxone is and what it does in the body. It's what we call an opioid. It's probably not a new term to most of the people listening, but opioids have the distinguishing feature of getting into the brain. And in the brain, they interact with certain receptors that release various neurotransmitters that make us feel good: dopamine, norepinephrine, serotonin. And so when we take these medications, they'll have a variety of effects. Some of them will be to treat pain. Some of them will be to slow down our gut and make people constipated. Other effects will be to make people feel good. So there's a variety of effects that can happen by taking an opioid. So it works in both directions. When people start taking an opioid, a low dose will have a really big effect. If they take it for a long period of time, that effect weakens and they need a higher dose to achieve the same effect. And usually they get to a point where there's a steady state where they're getting the good things that they want from the opioid, and whatever side effects are minimized. Coming down off of Suboxone, it's not an easy thing, because if you abruptly remove that medication, your body kind of goes into a bit of chaos. It's used to having that extra amount of the neurotransmitter in the body to produce those effects. So if you remove it quickly, your body's in a bit of shock and you feel sick from it. How can we minimize this? We try to help people go through this process in a controlled way, in a slow way that really minimizes the discomfort. So that's what we mean by a taper off Suboxone. It means slowly removing it so that your body habituates and doesn't go into a really rapid, uncomfortable state where it's abruptly withdrawn. Eric, do you have anything to add to that?
You know, I think the most important thing when people think of a taper, from my approach, is that individuals think that the taper is a end all to everything, and that we're not going to be able to come back or increase. The taper, in my opinion, is kind of, it's like a ride. You might come down a little bit, you might have to go back up a little bit, and then it kind of moves through a process. Just like Dr. Armington said, there's many neurotransmitters in the brain that this medication sits on, like a golf ball on a tee, and it gives you that euphoria. And it's important to not take that away immediately, because then you will suffer those unpleasant side effects from removing that medication. So
you, Melanie, did you have anything you wanted to add?
Just with tapering, and when you have someone that you're working with, and approaching it in a very team-oriented way, where the patient is definitely on board and able to voice their opinions, and focusing on slow and just maintained reduction. I've seen a lot of, well, I have to hurry up. I have to taper. I only have this amount of time. And those are instances where I've seen a lot of difficulty in achieving maintenance doses, and just kind of not really acknowledging that, we are kind of more moving toward a viewpoint of, especially buprenorphine and Suboxone, is to chronic opioid dependence as what insulin is to diabetes. And just understanding that this is a chronic lifelong illness. And while it's not appropriate for a lifelong interaction for every patient with Suboxone, it is in some instances what is the lesser of the evils. So that would be the only thing I would add.
Thank you. Is there a standard length of treatment that someone would expect before they begin to taper? And part 2 of that question would be, what considerations would go into deciding when the taper would start?
Shall I take a step? Oh, go ahead, Eric, you start.
I was just gonna, I love this question, when it was written, because I tell my patients this when they ask me this question. I wear glasses just like Dr. Armington, a couple other folks, millions of people. I don't wake up one day without some type of intervention and can see perfectly. And I view that the same way with medication. You have a physiological dependency on an opioid that we're counteracting with Suboxone to help keep you alive. Just like it's blood pressure medicine, just like it's insulin. You don't wake up one day in which you're like, okay, I'm perfect, I'm done, I don't need anything. So that's kind of where the discussion of the taper comes into play. However, there are studies that kind of put what we call evidence-based practice, best guidelines that are out there that say, okay, maybe after this period of time, it is safe for an individual to start considering tapering. I coach my providers, and I believe it should be a collaborated approach between the patient and other folks with the taper process and what that length of time is. Now, there are studies that show that if you taper too quickly, or if someone wants to be on it for 6 months, the likelihood of them relapsing is almost as high as 90%. So what is the length? I consider maybe 18 months to about 2 years, maybe around that time frame. It could be longer, it could be shorter, it could be 6 months to a year, but you want to have some type of stability, one where you get the physiological dependency out, and then you start working on the psychological dependency, which can take a long time to iron out the trauma and other impacts that have maybe caused you to go down this road of addiction. You have to bring back those connections that maybe you've lost because of your physiological addiction and what things you've done to get to that point. So that's my first statement. The considerations that I take into starting a taper, it is really, I bring it up periodically, maybe once every 3 to 4 months with the patient, discuss how we do it. I hit my space bar, sorry. I discuss with, about every 3 to 4 months with the patient, and I ask them, hey, how we're doing? Where are we at in this process? How are you feeling? And a lot of times I kind of let the patient let me know that, hey, I've been kind of tapering a little bit on my own. And I'm comfortable with, let's try and remove the Band-Aid a little bit and you prescribe a lower dose. So now that I know I don't have it, then we'll continue on with this as well. So I'll turn it over to Dr. Armington now.
Yeah, I think that was very well said, Eric. And I think you really kind of, you touched all the most important points. When you look at the literature that's out there, there's not a lot of guidance that says you should be on methadone or Suboxone for X amount of time. What the studies do suggest, if you look at them in general, is that people who are on treatment longer do better in the long run. They have a lower chance of going back to using drugs. Now, these are studies and people are individuals. So the most important person in this whole process is the person taking the medication. And we can offer our opinion about that. But it's the person who's taking it really needs to be ready. Now, they may feel that they're ready, and the clinician may feel they're not ready. Okay? And it's our role to say, it's probably a little too soon for you to come off of this. Eric alluded to, the psychological aspects of addiction. The physical aspects are one part of it. And I say this to everybody when I start them on Suboxone or methadone. It's like, this is going to really help you with the physical aspects. That's one part of addiction. The other part that's really important is the psychological aspect, and that takes longer time to really address. There's not a pill for it. There are things that are more labor intensive. You have to learn how to talk about your feelings, conflict resolution, dealing with things that have happened in the past that you need to clean up, learning how to deal with stress without, grabbing for a substance. These are things that take a while. We generally say 18 months, 2 years, as Eric was saying. That gives your body a chance, and your central nervous system some time to really heal those pathways and to get back to operating without having those wild rides of heroin and oxycodone and so many different things changing the chemistry so rapidly. If you've been on it for 18 months, 2 years, and things are really stable and you want to start to come off, by all means. Some people never come off, and there's nothing wrong with that. I've had some patients who have really wanted to come off, and we've done a slow taper, and they've got down to, this is a question that is going to be asked later. I'm sort of anticipating it, but they ask, they say, I don't want to continue this taper. I want to I want to go back up. I'm too uncomfortable. This is not right for me. And there really is a scale here. And the person who decides what the next movement is going to be is the person taking the medication. We're there to guide you, give you as much of our experience, and tell you, interpret the medicine for you as much as we can. But you're the most important person in deciding when it's time to come off.
It was so good to hear all of that. I mean, and as a recovery counselor who's, working on all of those broken connections in the brain because the average age of initial use is 12 years old. And there isn't a 12, 14, 16-year-old or any year age person out there who picks up for the first time and says, you know what? I really hope that I get to go and see Dr. Armington one day as a drug addict and need to be prescribed this medication. That does not happen. And what we're finding, comorbidities are not the exception. They are the rule. We expect that when someone comes in who is dealing with issues with addiction or dependence, especially with opiates, there is significant amounts of trauma, and not just one or two instances, but complex periods over decades of time. And, when you start getting in there under the hood and start going through all these things, that's a lot of, cognitive, behavioral, dialectic, validation, and learning new coping skills that can, take an effective place, a healthy place for the not so healthy choices that were made previously to encourage the addiction and the dependencies to develop. So I was really glad to hear there's absolutely nothing wrong with someone being on Suboxone for a lifelong period of time.
And if I could just add one more thing to that, it's not unique to addiction to not want to be on a medication for long term. If I start somebody on a medication for their blood pressure, or for their thyroid, or for HIV, almost universally, the patient asks me, how long do I have to be on this? Nobody wants to go on a medication forever. And I get that. I really understand. Nobody wants to feel tied to something that if in the absence of, they're going to feel really sick, or they're somehow dependent on it. And so that's something that you have to kind of wrap your mind around. someone asked a question about high blood pressure, and they said, you know, if a lot of people could come off of their blood pressure medications if they really committed to exercise and diet change and low salt, but not a lot of people are going to do that. So the best way to control that is to stay on their medication. And that may be the conclusion that somebody with opioid addiction reaches as well, that it just is, it's too uncomfortable. I don't want to go through that. I do really well when I'm on Suboxone. So it's a valid choice. There's nothing wrong with being on it long term. Don't feel, you know, like it's a unique thing in opioid addiction to think that you don't really want to be on a medication long term. Everybody feels that way with pretty much any disease.
Thank you. And so I feel like we've answered this one, but it was one of our planned questions and it comes up a lot. So I'm going to ask it anyway. Does everybody have to taper off Suboxone or, you know, their other buprenorphine medication? Is it like just expected? You just have to do it sometime in your treatment?
I think Dr. Armington answered this question very well, and I will reiterate. No, this medication is saving your life, just like blood pressure medication, insulin, just like maybe thyroid medication. You don't wake up. We haven't discovered the cure yet to wake up and control our involuntary system to change what is happening in our body. So the taper is a conversation that is something that we like to have with patients, but it is not necessarily a, this is it, 6 months, you're done type of situation.
Now, a question that comes up very often, right from the start, like often even before people begin taking their prescription, is what does it feel like to taper off?
You know, sorry, Dr. Armington.
No, please go ahead, Eric. No.
So with it being a partial agonist, the taper off of Suboxone is going to be less severe, or the withdrawal, if you will be less severe from that versus, you know, maybe having cut cold turkey from methadone being a full agonist, or cut turkey from, you know, if you're utilizing heroin for a lot of periods of time. But the taper is designed, the micro taper, which means coming off really, really slow. It's designed to minimize the impact on you, the patient. So just like Dr. Armington said, the person that is controlling the taper is the patient. So if they tell you, hey, I'm starting to feel a little bit of withdrawal, I had some body aches, I had some nausea, I was a little bit irritable, well, let's just come back up a little bit and maybe we redesign that individualized taper. There's no set like 3 here, 2 here, 1 here type of guidelines. We really have to approach it from an individual patient focus.
Thank you, Eric. Does anybody want to add on to that?
I will say that, you know, you're going to feel it. I mean, you're going to notice it. It's probably not going to be completely discomfort free when you go through a taper. And we have ways to really make it less difficult. The slow taper is part of it, you know, letting your body really adjust for as long as it takes. There are also other medications that we can give in the short term. If you're feeling, usually in the beginning, people feel more the ear, nose, and throat stuff, runny nose, and tearing eyes, and then it can progress to more abdominal stuff, upset stomach and body ache. And so depending on if you experience any of these symptoms, we can treat them specifically. For body ache, we can recommend some anti-inflammatories. If you're having nausea, we can write a prescription for something to deal with the nausea. I will say that I think for most of the patients that I've seen go through a taper, they've been surprised at how well they've been able to tolerate it, because they kind of have a nightmare in their mind about what it's going to be like. But I don't think we should also give you the impression that you're not going to notice it, because you probably will notice it. But in a way that's going to be as tolerable as possible for you.
Excellent. A lot of people really do have a lot of fear about withdrawals and symptoms when they taper. When a patient comes to you with those kind of fears and concerns, How do you respond to them?
I think just like Dr. Armington said, is that there is solutions for those fears and concerns. I think the biggest thing is, from my personal experiences, is, you know, when my sister's an addict, still is, when she gets high and she can't get her next fix, she gets dope sick and she's miserable. And that's the unfortunate picture that I see, that that's the fear that they fear when, you know, patients were coming off of maybe Suboxone. They're going to get that miserable sickness because, one, maybe they can't afford getting another what have you of what medication that they're taking. Two, they can't find it, so they have had that miserable come down from, you know, withdrawal. So the viewpoint that we look at, you know, especially in obviously Dr. Armington will agree, is that, you know, we can manage these symptoms. As it's not going to be pain-free. You might have a little, you know, abdominal upset, maybe you have runny nose, maybe you have some withdrawal symptoms, but we want those withdrawal symptoms to be as minimally impactful as possible. You know, we can give Zolfran for nausea and vomiting. We can, you know, give other medications to combat, you know, maybe irritableness or insomnia. Maybe we give you some medication to help you sleep at night or calm you down, things like that, that help counteract that taper process of that fear of the pain or the unknown.
What I think is the fear, I'm so sorry. The fear component of it is really something that I think anyone considering tapering would need to really address with their counselor and really talk through at great lengths, so that their counselor is then able to talk with their doctor and make reasonable plans and prepare the prescribing physician for, like, hey, you know, this is what they're expecting. You know, let's work on understanding things as a group. And, you know, I think it bears mentioning that the majority of physicians prescribing Suboxone out there don't really have the outlook that we're seeing here today. Unfortunately, it's a lot more cutthroat. It's a lot more, okay, well, you've gotten through detox, good luck. It's not an extended, holistic, medically assisted therapy as it is here. So I think that the fears are very real, because that's what society and this population is experiencing. They know someone or have gone through it themselves. And while it may just be a little bit of nausea and some uncomfortability, others may have extreme forms. It's all over the internet. I mean, there's always someone with a horror story. And because most people who have come to Suboxone at one point, you know, they're very familiar with withdrawals are like. And that fear being planted into the reward center is always going to come back to the front and dominate decisions and control that amount of fear. And I think it's our jobs to take that fear seriously and work through it to make sure that we're providing facts and looking at, you know, all aspects of the fear with that patient, specific to them and their life and their expectations.
I think one other thing to think about too is why you want to stop. And, you know, your motivations are really important. And if you have really good reasons and you really feel ready to do this, then you're going to be motivated to go through this process. And if there is a little bit of discomfort along the way, then it's going to be acceptable to you because your goal is to come off the medication. I think for somebody who's, you know, a young person who maybe didn't have a long opioid history, it's much more reasonable to think about, you know, you're going to be on buprenorphine for a short period of time, or, you know, a medium amount of time, and then eventually come off of it. And it's not something that you will need to take for the rest of your life. Somebody who's been using opioids for decades, or has had multiple attempts at treatment and just can't function without them. It makes more sense to think about it as the long-term chronic approach like we were talking about. So I think, if you're really nervous, you've made a decision you want to taper and you're really nervous about it, have a discussion with your provider about why. And maybe, the people in your support network, loved ones who know you're in recovery, who support that you're in recovery. And make sure you're really clear about why you want to do it and if it's reasonable. I think if you can you get clear answers to both of those things, you're going to be successful in doing the taper.
Thank you. So one of the questions which we have already partially covered, have you had someone begin the tapering process and then go back up to their regular dose? And are there any effects of that, or is that just normal?
I've certainly had that. This is one patient, really wonderful guy I've been taking care of for a long time, and I just really love him. And he, every time he gets down to 2 milligrams, he'll stop, and he's miserable. And so we put him back on, and that's just his dose. He's not going to give it that 2 milligrams. There's nothing wrong with that. I've had other patients who have gone down quite a bit and decided to go back up. I had one patient who he was going to a wedding and he was terrified of his wedding. We'd been doing a very slow taper. And I said, why don't you just go back up in your dose a little bit to get through this wedding, and then we'll start the taper again. And it worked really well for him. It took a lot of that anxiety about the event away. So I've certainly had patients who have gone down, wanted to go back up again. Again, it comes back to you're in the driver's seat. So, unless you're asking us to do something that is clearly likely to harm you, we're going to work with you on that.
I agree with Dr. Armington. It's the taper is totally, you're in the driver's seat. It's as perfect as that. If we need to go up, we go up. We match that. So, and I was listening to that. The norm out there in society is that there is a lot of providers that are just, here's your 3 to 6 day detox and good luck. And that's the problem. That's the problem. That's what we're seeing, the epidemic of overdoses and people just having a really rough time, is that there's not enough providers, counselors that are encouraging treatment as a solution versus trying to get them off, working at getting them off, versus like, hey, you still have that psychological dependency, you have trauma from your childhood, you have all these other things that enter into it. I could be on this soapbox for a while. So yes, I've had tapers go up and down, so we're good.
Thank you. There can be a lot of social pressure to stop medication-assisted treatment and be what traditional recovery considers totally sober. If you have a patient who is being pressured by their friends, their family, other medical professionals to get off Suboxone, how do you work with them either to talk to those people or to decide what's best for them?
If I could go into this one just a little bit with the psychosocial aspect of it. There was a really long period of time where a lot of the people that I was working with, just in your cognitive behavioral, just as a secondary support to NA and AA, and they literally would not disclose to their sponsor, their group, their family, that this was a medication that they were using to help them because of the negative connotations with it, and because of the way society views it, and because society doesn't know that it's not the same as methadone. It's a completely, well, not a completely, but it's a partial agonist. It does not operate in the brain the same way. There is a ceiling effect. You don't get those high levels of euphoria. And so one of the main things that I really try to focus on, and what I think Workit really does a great job of in the courses that are provided, is to give the absolute truth and the information, so they can go to their friends and their supports and their family and say, okay, I'm hearing what you're saying, but according to the American Medical Association, who, let's face it, might know more than you, this is what they're saying, and be able to understand how these, you know, advanced concepts are playing out every day in their brains, and running interference between the executive memory and the, you know, the more primitive parts of the brain, and how it's been, those messages have been intercepted by substance use over time. So really having a commonality, having a community, having people that you can count on, that you can tell the truth to and not feel judged, and have a safe space to do that in, and to have the absolute most current information that you possibly can have to arm you in those conversations, so that you can stay factual rather than emotionally charged.
I would agree with that. And, you know, it's mental disease can be very culturally specific. So you can have different cultures and ethnicities that have different viewpoints on what is considered sobriety, what type of treatment should you have, and what duration of that treatment can be. And I view, you know, medicine, or Western medicine, and I'm gonna put this in a bucket of everything, is that a few hundred years ago, we would treat epilepsy as a form of witchcraft. That if someone would have a grand mal seizure or some type of seizure, that they were maybe possessed, and we would do some type of treatment that right now we would view as being barbaric, but at that time they viewed it as being acceptable practice. So if you look at what is being done today, I know it's a far transition from what that was to what this is. Mental health is just something that still has a taboo in society, you know, where, you know, there's a book out there, it's the gist of the book is It's Okay for Men to Cry type of thing, where it's you view mental health, if someone has anxiety or depression, hey, just lighten up, buttercup, fix it tomorrow, you know, just muster through it, you're fine. So it's really, you're not fine, and it's okay not to be fine, and it's okay to have your treatment plan just with the people that you want in your circle. If someone's in your circle that's pushing you down a path that could make you do stuff you don't want to do, then they're not in your circle anymore. That's kind of my thought process, Dr. Armington.
I hear this a lot, and it's a difficult issue. And I think the most important thing is to empower you to be able to stand on your own 2 feet and say, this is what I'm doing for my sobriety. The hardest situations are when a spouse dislikes the fact that somebody's on Suboxone. Those are kind of special circumstances. Sometimes people need to conceal something for their own safety. And you do what you need to do, and you need to protect your sobriety. I very much encourage people to try to educate others about it. If they're not going to come around to their viewpoint, then fine. You know, they don't need to understand. They're not in your shoes. They're not dealing with what you're going through. And if you have found a solution for you, that means you're not going out and spending your rent money or putting a needle in your arm or ending up in jail, that's a good solution. You know, and nobody gets to tell you that that means you're any less sober. I'm a big fan of 12-step programs. I really support them, and I think that they have a role for a lot of people. Not everybody likes them, and not everybody needs them, but I think things are changing. But there's a strong feeling, especially in NA, that if you're taking a medication, that somehow your sobriety is compromised. And I just couldn't disagree more. And so sometimes I'll tell my patients, you don't need to let everybody know everything. If you get something from NA or AA, and you're going to get a lot of flack by saying that you're taking Suboxone or you're taking methadone. Don't tell everybody. You know, it's not everybody's business. You probably want to share it with your sponsor, with your close friends, but you don't need to share it in a meeting. You know, it's not for everybody. It's nobody's right to comment on that stuff. You know, the people who are really in your circle, who are your support system, you want them to know and be on board with what's going on with you. Other people, who cares what they think? You know, they're not the ones going through it. You're the steward of your own sobriety. No one gets to define it for you, just you and the ones that really are close to you in recovery. That's what I would say.
Thank you. And speaking to the need for a larger community, I do want to shout out that Workit Health members have access to our Facebook community and Workit Health community for people who understand what you're going through and who you can speak your truth to. And I know there are other medication-assisted recovery groups out there. So if you are finding yourself in recovery groups that are very anti-medication-assisted treatment, that there are options out there. What is the question that you hear most of all from your patients about tapering?
I guess what I hear is, what's it going to feel like? You know, what can I expect? Tell me what this ride's going to be like. And I think that, you know, I describe it as well as I possibly can, not being the person who's going to physically go through it myself, but these are the possibilities and these are the tools that we have to get you through it. And that's the most frequent thing that I hear.
I hear similar, and I also hear, is it going to, do I have to? Type of questions. And I usually just tell them, I tell them the same thing I started in the beginning. This medication can be forever, or it can be, you know, when you decide. So I typically go that path.
One other thing that I do hear is that are there long-term side effects, things that they could harm me by being on buprenorphine for a long period of time? And the short answer is really no. I mean, there are some side effects that people can get that tend to be more in the beginning, maybe some constipation, things like that. But in terms of long-term harm to your body, it's a really, really well-tolerated medication. And so if people are concerned that they're doing some harm to their body by staying on it, I try to allay their fears, because there really are not any documented long-term difficult, bad things that happen by being on Suboxone for a long time.
So we have a few questions from chat and from the Q&A box. One attendee says, I've attempted to taper multiple times and it always gets too hard when I get down to 2 milligrams a day. Some programs jump off from there. Some allow one more step down to 1 milligram and then jump off. It feels like too big of a jump and it causes a lot of anxiety. Are there any suggestions for handling the final steps of tapering?
Yeah, that final step is can be psychologically driven and have some physiological impact to it as well. Even though it's only 2 milligrams, it's still something that's going in and hitting those neuroreceptors in the brain. You can view those steps as you can do with any type of taper we do a medication. You could do 2 milligrams for a week, then you could do a half of that strip or tab or what have you for another week, maybe even have it, you do a half every 3 days or a whole every 3 days. So we kind of work on getting a transition that works well for you, because that next step off of it completely, in my opinion, is the biggest step, because that's your safety net that you're taking away, along with some other things.
I would add to that obviously you don't need to come off of it. You can stay on that dose. But there are certainly things that we can do to make it a little easier. We can talk about medications that will help with the side effects. You could do every other day for a while too. I mean, that's one other step that kind of makes it even a little bit closer to zero opioid. And we haven't talked at all about another medication that can be used beyond Suboxone, after Suboxone, that's really successful, and that's naltrexone, or the long-acting injectable version is called Vivitrol, you might have heard of. And it works in a very different way than buprenorphine, Suboxone. Very effective though. And I've had a lot of patients transition really successfully to coming off of Suboxone and going on to naltrexone and being really happy and comfortable with that change. So that's another option. One other thing I'd add as well, if anxiety is a big component, make sure that you've explored that before you stop entirely. Do you have an undiagnosed or untreated anxiety disorder or depression? And if that's the case, starting some medication or having an approach for those things, a way to deal with those symptoms will make it easier for you to get over that last hurdle.
Just piggybacking off of what Dr. Armington said, I've had quite a few times where I've worked out not necessarily a safety plan, but a safety plan with patients when they're deciding to taper, and just taking it off in chunks. And okay, what are we gonna do? What can we do instead that we feel good? And just identify those things that are desirable activities, things we enjoy doing, and just checking in a lot more often. And always remembering that it's, that the medication is assisting us with the therapy. It's removing those biological and physiological awfulness to be able to get underneath and find out what started it all to begin with. So making sure that you have that tripod of patient, medical, and psychosocial in place is going to keep you a lot more stable going through any part of it, but especially with tapering, because it's another big change. And the previous experiences with coming off of a medication are usually not great, when we're looking at coming off of opiates in general, traditional opiates. So just remembering that you have a therapist out there who cares about you and just wants to help you with those anxieties.
Thank you. So we have two questions that are very related to that last one. The first one was, how long do you wait between stopping Suboxone and starting Vivitrol or naltrexone?
Dr. Armington probably is more of an expert in this, but from my experience, you want to have a taper off of the Suboxone, and as you taper down, you want to have a period of abstinence between the taper and starting the either naltrexone pills or the Vivitrol long-acting injectables. We take into consideration the half-life of Suboxone, how long it stays in your system, all the medical terms, but usually it's about a week to two is what I've seen. And Dr. Armington, you can interrupt and inject on that one.
No, I think you said it just right, Eric. It's 1 to 2 weeks after your last dose of opioid. Naltrexone and buprenorphine really clash. They do the exact opposite things. So if you have them overlap, your body is not going to like it. It's going to really let you know. So we try to give you that full washout period where the Suboxone is completely metabolized, and then you can safely start the naltrexone.
And then the other related question about that last little jump, are providers able to support tapers less than 2 milligrams? Are they prevented from offering support with film cutting? Our local health department offers support for this for micro inductions, wondering if it's common or possible for tapers as well.
I have many patients that are on fractions of doses, 1.5 films a day, or maybe they take 8 milligrams, one film, and they take it in the morning and it's just not working for them for the whole day. So then they take a half in the morning, half at night, or they break it into thirds, and that works for them. So microdosing, that we have guidelines on microdosing. There's evidence on that, and Dr. Armington has an essential amount of knowledge he can probably add into this.
What I know I've learned from patients, this has really been, I think the people who know most about this are the people who are going through it and what they bring to us. I've really learned from people who've gone through it. If you followed the exact instructions in the package insert, you'd lose a lot of people because it's very rigid. And there are certain things that we really absolutely need to make sure of. We're not mixing, for instance, Suboxone with other opioids. That's a really bad thing to do. But in terms of we used to be taught that you can't cut the strips. It's going to make it inactive. That's not true. You can cut the strips. So, people try things. They let us know. And there are creative ways to get down to the lowest dose possible. The lowest dose that I will recommend to somebody is taking a 2 milligram strip and cutting it into quarters. Maybe you can cut it into eighths. So that's either going to be a 0.5 milligram or 1/4 milligram. There are probably ways to go lower than that. I don't know them yet. If anybody brings them to my attention, I'm curious to hear about them. But remember, your body is the barometer, and it's going to tell you whether it's working, whether it's not working. It's hard for us to recommend things that don't have like a study that's been done, because we don't have quote unquote evidence-based medicine. But in the real world, people do things, they find out, and they share with us, and then we pass it along to you guys.
Excellent. Also from the chat, someone says that they are not debating that long-term taper is often, supported by evidence, but if it is, at the end of the day, it's my life. If I want to start tapering in 6 months and I come to you as my provider, what would you do? How would you respond to that?
I've had a couple members, patients that I've inducted and done an induction, got their whole health history. And, I ask, what's your goal? What are you here for? What do you want to accomplish? And if they're very driven and they have the right tools put in place, I can't force anyone to take the medicine that I want them to take. At the end of the day, they are in the driver's seat of this journey. So I've had a couple people that have been successful, but just like Dr. Armington said, there's evidence-based practice that gives us these parameters and these studies and things, and we are very statistically oriented, where we see that statistically the numbers are not in everyone's favor. The longer you have to work out the demons that are maybe in your closet that have brought you to that path. So but if you're very motivated, it was a short-term use, I'm for it. I'm not going to force anyone to take medication. I'm here to say, this is what I recommend. And with my expertise and what I've taught, learned, this is how we would treat this. But, if someone is highly motivated, then they're highly motivated.
Yeah, I think that well said. I think, people with addiction here know way too often from the medical establishment. And that's not the answer we want to give you at Workit Health. I've had patients who say, I'm coming to Workit Health just to taper down. I've been on Suboxone for a month. I want to come. I don't think this is the greatest thing in the world to do, but if that's really what you want to do, I'm going to help you do it. And I'm here for you if you want to come back to treatment and try it a different way. But if somebody wants to come off of medication, I'm going to help them do that. I mean, I don't have any interest in keeping people on a medication longer than they want to be on it. And I'll express my viewpoints, but we're here to help you.
Person-centered care. Love it.
And then the final question from chat is, when does the conversation start with your members about the tapering process?
Day one. I think it's something that you put out there that is an option, that it could be a short-term solution or it could be a long-term solution, but it starts day one, but it also starts when the patient is ready to have that conversation. You might have someone, which I've seen, that their life is such in shambles, they're homeless, they don't have clean clothes, they don't have the bare minimums of fresh water and food, and let's fix these two things and let's get these things stable, and then we can start putting more things on your plate. You don't want to stress someone out and say, okay, well, we're going to fix you for 30 days and then you're on your own. So I think that it could be a conversation that happens day one if the patient's ready to hear that conversation, or it's ready whenever the patient wants to have that conversation as well.
I don't generally bring it up. I wait until people bring it to me. A couple circumstances where I've had somebody who's been just really doing well for a very long period of time, and I'm, on a low dose, and I'll bring it up. Is this something that you'd like to consider? But generally, I wait till it's presented to me to talk about.
And then finally, I just wanted to talk about, a lot of people think of Suboxone tapering as like the end of their treatment. And there are, options for support after. So I wanted to see if, especially Melanie, if you want to talk about psychosocial support and other kinds of care that people get after the taper.
Yes, I was going to add on to the last part there, but I thought, well, this would fit better somewhere else. So I'm glad that this is here. A lot of times what I will talk about with my members is, okay, so how long were you active in addiction? 12 years. Okay. And you've been working in and out of recovery for the past 6. So that's like almost 20 years. And you've, gotten down and done your tapering. It's been 2 years. I'm thinking that maybe that's not quite evening out. And I think it would really help you to extend the work that you've been doing and maintain the work that you have already accomplished by continuing to go through all of the different psychological, emotional, traumatic components that, so that there are coping skills in place. There are safety plans in place. You know what to reach for instead. And, it increases the likelihood for a successful and long-term recovery, because, recovery is a lifelong change. And we're always watching out for triggers that are going to cause or might cause relapse, and being careful to really evaluate those and look to those supports that are in place to kind of help us navigate through that. And after we've tapered and things look a little bit different, even though it's not much different, it still is different. And having that same team and that familiar face to just kind of bring you back to center and talk things through and validate your concerns and hear what you're saying and meet you where you're at and let you know that there's no judgment, there's no shame. If, there's a number of things there. I had a member that went through a horrific traumatic experience and had recently tapered and found that it would be better for her just for a little while to return to a half dose. And that's what worked for her. So I think maintaining that mental health support and that psychosocial component to recovery, long after tapering, and whether that's, with Workit or you end up moving on to an individual therapist in your town that you see every month or so, just to remain accountable and make sure that you're kind of keeping your eyes open, as it were. But it's something that we want to continue to give you support for, and that's why we're here.
Thank you. I want to respect everybody's time, but I would also like to give you a chance to close up. So is there anything that you would like to say on this topic that we haven't addressed before we finish?
There was a question, I don't know, maybe it came to me. It was a question about when dosing twice a day, what are good times to take the medication? How far apart should I take the dose? Is it normal to keep me up at night, or is the Suboxone the thing keeping me up at night sometimes? I usually, it all depends on the symptoms that are happening. If you're having symptoms because you're having maybe insomnia or anxiousness, it could be some underlying factors that are going on. But typically, most of the people that do twice a day dosing will take one in the morning and maybe one around lunch, or not lunchtime, but like dinner, 6, 7 o'clock at night. If you see that you're taking it at night and you have a theme of it keeping you up, I would try to maybe back off of that, maybe take it a little bit earlier in the day, and see if that would help offset, you know, the maybe the mind racing or the jitteriness that you're having at night.
Thank you.
The only thing that I'd like to add is if you have, you don't edit yourself from asking questions of your medical provider or bringing up things. If you have a question, someone else has had that same question. There really are no stupid or offensive or wrong questions about how to treat opioid addiction. You know, what could make your treatment better? Could you try this? And I think that you should feel empowered to bring all of those things up. We've probably heard them before, and we may not have exactly the right answer, but we will work with you on it and try to find the right answer. But you know, please don't hold things back. Talk to us about what's going on in your life and in your recovery, and let us know any questions you have.
Elaine, if I could ask real quick on behalf of one of the viewers who was rushing home to be able to watch the webinar and didn't get home in time. I know that we did record it, and are you going to be posting a link for everyone to view after?
Yes, so we will get this up on YouTube. Usually it's late, so afternoon of the following day, so look for it tomorrow. It will be on the Workit Health YouTube channel, where we have actually a lot of videos if you haven't checked it out. And we will also email a link to everyone who registered for this webinar. So if you missed it, we will email you the viewing link. And I'll drop a link to our YouTube channel in the chat.
Elaine knows it all. Thank you so much.
Thank you.
Thanks to everybody who took the time to come to this. It was really nice to have people come in and share their thoughts and ask their questions.
Yes, absolutely. And let's see. Did anyone else have any final thoughts before we close up? No? Okay. I would like to thank our panelists for sharing their expertise and insights today. It was very, very helpful. And thank you to all of our attendees who joined us and who asked really thoughtful, great questions. You can find us online at workithealth.com, and on social media, we are Workit Health pretty much everywhere. And we look forward to seeing you at a future event.